Thanks, Shavina. Morning, everyone. I'm Leila, one of the registrars, as Shavina's introduced me. This morning, I thought we'd talk about a topic that we may not necessarily see that often, but we see it enough for it to be something we should know about and be familiar with. So I think I'm a bit biased being at Red Cross. We see this quite often here, and it sometimes poses a management challenge for us because it's a significant enough problem for these patients and their families to seek help for. So I think that's why I thought it was important that we cover it. So I'll just jump right in. I've got no disclosures. I will start with a case presentation, and we've got consent from the family of the patient to share all the information for academic purposes, and I've acknowledged all my references. So starting off with the case presentation, our particular patient is a 10-year-old girl. She's known with Moya-Moya disease. And just for, I didn't know what this was before, so just for those of us who don't know, it's a rare progressive vascular disorder of the cerebral vasculature, which causes stenosed arteries in the basal ganglia. Unfortunately, she suffered complications from this and had 2 previous strokes, and this left her with bulbar dysfunction with sialorrhea. She was initially referred by the pediatricians to speech therapy, but unfortunately their interventions didn't give her that much improvement in her symptoms. And
Leila, your volume has the sound's gone off. Leila, can you still hear us? Apologies, everybody. We're just trying to sort the sound problem out. Just give us a second. Hi, Leila, can you hear us? We still can't hear you. Leila, can you unmute yourself?
sorry about that.
I'll
just share my screen again. Yeah, can you hear me, Shavina?
Oh, we can hear you now. Yes.
Okay, and you can see my slides.
I can see your slide. Do you want to go back one slide?
Sure.
Yeah.
So she was seen by the speech therapists. She had minimal improvement with their therapies and was then referred to us for advice on how we could better manage this problem. And specifically, the parents were concerned that she was having this constant odor. She was having to wear an apron to keep her clothes dry, but she was still, her clothes were still getting wet, and she was also experiencing some social exclusion at school. So we started on a PPI, just in term, because we know that reflux can worsen the problem. She was still attending speech therapy regularly. She was assessed as a poor candidate for any intervention requiring a general anesthetic. She was very high risk because of her vascular condition. And therefore we discussed with the family about Botox injections, for which they were keen. So we went on to do an ultrasound-guided Botox injection to a bilateral parotid and submandibular glands under local anesthetic and some sedation with success. And in terms of her outcome, she didn't have any immediate complications. And on a 2-week telephonic follow-up, consultation with her mum, she's still wearing her burp, but there's been a significant subjective improvement in the frequency and amount of drooling that she's experienced. And we do still expect some further improvement a few weeks and months down the line. So in this presentation, what I aim to do is just define the problem clearly, speak a bit about the pathophysiology, and then in detail cover the background assessment and management of the drooling child, and then also provide an update on what contemporary management strategies we have as options. So drooling can be defined as the unintentional loss of saliva and other oral contents from the mouth. This is a normal phenomenon in babies and infants, but when it persists beyond 4 years, that's when it becomes neurodevelopmentally abnormal. In terms of patient population, almost 2/3 of children with cerebral palsy drool, and its management is very reliant on a multidisciplinary team input. Sialorrhea can be classified as acute or chronic. Acutely is generally in the neurodevelopmentally normal child, and this can be as a result of inflammation or infection of the oral cavity, dental disease, even things like teething, epiglottitis or abscesses in the oral cavity, sometimes rarely neoplasms, and also drugs like anticonvulsants. Chronically, it's generally seen in the neurodevelopmentally abnormal child, or any child with a specific ORO-MOTOR difficulties, and this is because of inefficient tongue or bulbar control, and the patient's head control and posture also play a role and are important. Just a bit of epidemiology. So the overall prevalence of significant drooling in childhood amongst all childhood populations is about 0.6%, but the commonest group with severe and persisting difficulties is those with hypotonic CP, and amongst that population, the drooling prevalence approaches 50%, so about half that population. Just a bit of physiology of the control of saliva. So salivary excretion is under control of the autonomic nervous system. So you get parasympathetic, so you get the salivary nuclei in the pons as well as the medulla. You get parasympathetic system causes secretory excitation, and the sympathetic system generally alters the viscosity of the saliva. These are all regulated by external somatic stimuli like vision, smell, and taste. The parasympathetic fibers synapse in the otic ganglion as well as the submandibular ganglia. And then the post-ganglionic parasympathetic fibers will release acetylcholine at its nerve endings, which directly stimulates the secretion of saliva. So why is drooling a problem and why should we treat it? So there's multiple concerns, hygiene being one of them. It causes soiling of the clothes, their toys, sometimes electronic devices if the children are of that age, or even attending a school where these things are used. And this was the case in our patient. It also causes skin irritation. As you can see in the image, you can get some chin or perioral abrasions, maceration of the skin from constantly being wet, causes social isolation, and as well as there's concerns for aspiration, and these children might present with recurrent chest infections. Overall, all of these contribute to the child having a very adverse kind of impact on their quality of life, and it does increase the burden on caregivers in a patient population that's generally already it has quite high care demands. In terms of clinical assessment, so as I mentioned earlier, multidisciplinary team assessment is vital. We aim to get the speech therapists, occupational therapists, sometimes the dentists, as well as pediatricians all involved. In terms of history, so we want to quantify the severity, and for that you can use a visual analog scale, which I'll go through a bit later. Other things you must ask about is the child's ORO-MOTOR control, any aspect that might increase drooling, so posture, if they're on medication, like I mentioned earlier, anticonvulsants, if they've got dental disease or if they're teething, and then what they call ENT symptoms, so if they've got nasal symptoms, if you suspect adenoid hypertrophy, rhinitis, rhinosinusitis, sinusitis, as well as their neurological status. And trying to elicit features of reflux and features of aspiration is also very important. In terms of exam, so you're looking at excluding any dental disease, you're looking at their postural control, their mouth, tongue, and jaw movements, any neurology of the tongue, so if the cranial nerves are intact, if there's bulbar dysfunction, if their swallow reflex and function is intact. Good examination of the nasal cavities is important, which may or may not include a scope, as well as a respiratory exam. So in terms of quantifying the severity, so you can ask the parents or the caregiver to keep a bib diary, and this gives you quite a rough measure of how severe the drooling is for that patient. But then there are more objective measures like the drooling impact scale. So this is what we actually use at Red Cross. It's the image at the top. It's kind of a visual analog scale. It includes 10 factors or questions that you ask the caregiver, and then you score them out of 100, and that gives you an idea of how severe it is in that patient. There's also the drooling rating scale. It's slightly older, but also still in use. And basically both of these scales focus on how disruptive the drooling is on the general quality of life for that patient. In terms of guidelines, so the NICE guidelines from the UK were published in 2017, and they specifically focused on the management of cerebral palsy. It's the first issue that of this guideline where the specific issue of salivary control was mentioned, and they've given an extensive evidence-based recommendations for management. And I found when I read through, it's quite useful as an international reference, but the relevance in a more resource-limited setting is fairly limited. So it's good to know what's available and what options there are, but obviously it has to be applicable to your setting, and some of the things they mentioned are not necessarily applicable or available in our setting. So I'll go on to the management now. So generally it's classified, or you can see it as there being 5 approaches, but they're not necessarily mutually exclusive, and you may you need to decide based on the patient you see where you start and what is the most appropriate. So I'll go through each of these in detail and focus specifically on the surgical interventions. So in terms of conservative measures, you can offer kind of things like skin protection. So counsel the caregivers on dabbing rather than wiping to cause less skin inflammation or irritation. Also, the use of barrier emollients to the skin can be useful. Dietary modification, so avoiding sweet or carbonated drinks and acidic food. And then there's kind of the alternative therapies like acupuncture and homeopathic remedies. There's very small kind of individual case reports where there's reportedly good outcomes, but there hasn't been any large scale, good quality randomized control trial or anything on this. So if it's available, they say you can try it, but if not, it's not necessarily going to have the biggest impact. Then ORO-MOTOR exercises. So this is coordinated by the speech and language therapists, and it's said to improve facial tone, increase sensory awareness, and also help the child to develop voluntary control. The evidence base for this is also very limited, and it's actually only applicable to children who have a milder dysfunction, good cognitive skills, and a high level of motivation and support. And the literature is quite clear in that it's not very effective as a sole treatment. So it always needs to be supplemented with some or other kind of management strategy. Intra-oral devices. So I've put a picture of one of these palatal training appliances in the corner there. These are said to be very effective in children with mild to moderate difficulties with controlling their drooling. They encourage active lip, tongue, and the aim is to prevent passive spill from the front. There is a risk of aspiration or airway obstruction, and it's definitely contraindicated in epilepsy. And then there's this I just thought I'd mention radiotherapy because it has been used in adults, but it's not actually recommended in the pediatric population. And this is mainly because of its side effect profile, which is unacceptable. So it causes a bad mucositis, xerostomia, dental caries, even osteoradionecrosis, and these children are also at risk of radiation-related malignancy. The relapse rate was also said to be very high, 15 to 20%, according to some of the studies. Okay, so moving on to the medication or pharmacological therapy. So options are anticholinergics. There's also some other pharmacological agents, and then botulinum toxin A injection. So in terms of the anticholinergics, in terms of the mechanism of action, so they cause, secretion of saliva, as we know, is under the parasympathetic control of the autonomic nervous system and mediated by acetylcholine. If you downregulate acetylcholine, this will theoretically lead to a reduction in the production of saliva. And so that's the basis for the use of these drugs. All these medications are used off license though, and examples of these are atropine, which is used here at Red Cross, as well as scopolamine, not necessarily available everywhere. And this shouldn't be initiated unless you've had a careful discussion with the parents about potential side effects. Other agents, so things like antipsychotics or tricyclic antidepressants, they can cause dryness of the mouth, but they're not generally used for that effect in children. Some people use antihistamines and then anti-reflux drugs. These don't control or prevent drooling, but they do prevent the problem of reflux, which can potentiate the drooling issue. Moving on to botulinum toxin A. So there's been considerable work looking at Botox injections into the salivary glands in an attempt to give a longer lasting effect on managing the drooling. And these, so how it works is that it irreversibly blocks the release of acetylcholine. It's said to have a quantitative and qualitative benefit, and this is between 1 to 6 months. But the maximum benefit is actually seen at 4 to 6 weeks. Potential side effects, so in the acutely, they can get some local bruising, some pain, and some swelling at the site of injection. And chronically, they get thickening of their secretions and also what they call a post-Botox dysphagia. And that specifically occurs if the injection is placed in the incorrect area, and I'll give some advice and tips on how we can prevent that. There was a European consensus statement published in 2016, which recognized that it is an off-license use for the use of Botox, but it has been recognized in peer-reviewed documents as causing a reproducible benefit, and it's actually said to have better subjective outcomes than any of the pharmacological agents I mentioned previously. So in terms of the technique, and this is how we performed the Botox injections on our patient. So how you prepare the solution is important. So you get a 100-unit vial of Botox, and you mix that into 2 ml of 0.9% normal saline. You should always apply a gentle and local anesthetic topically if you have that available, that you can see in the image here, because that gives good relief at the injection site. And then in terms of sedation, so it depends on the patient and whether you think they will tolerate it or not. Some patients may not need sedation and the local anesthetic may be sufficient, but if you need sedation, there's various agents you can consider. In some institutions, it's done under general anesthetic, but in our patient, that was not an option. It's recommended that you always use ultrasound guidance, and this is so that you have a targeted injection and it prevents the injection of the drug into the incorrect area, which could cause long-lasting side effects. And then the total maximum dose is important. So it's said to be 50 to 60 international units. And what we do at Red Cross is we do 15 units in each submandibular gland and 10 units for each parotid. Okay, moving on to surgical interventions. So these should be considered when your conservative measures or Botox injections have failed or were not an option even maybe. Surgical treatments can be used alone or even in combination or in succession with other treatments. And some children will gain considerable long-term benefits, but for others, only a temporary improvement. And this is very important to discuss with the caregivers before you embark on this. So the indications are few. So they should generally be more than 5 years old. Some people say they should be post-puberty. Failed non-surgical management is an indication to consider surgery, and also they should have a stable neurological status. So not in someone who's in a state of where their pathology is still in evolution. So here are some of the surgical options. So transtympanic neurectomy, salivary duct ligation or transposition, and also gland excision. So the mainstays of surgical intervention have been the submandibular duct transposition or relocation, as well as submandibular gland excision. But both of these can come with significant morbidities and a prolonged inpatient stay. And all the way back in 1999, a couple of surgeons described the submandibular and parotid duct ligation, which has actually gained a lot of popularity and is used quite widely. And I'll go through each of these approaches and just explain to you the pros and cons of each. So transtympanic neurectomy. So this is also quite an approach that's been around for some time. And what it is that you use a transtympanic approach to transect the nerves of the tympanic plexus on the promontory and the chorda tympani as these nerves traverse the middle ear. The advantages of this procedure is that it's technically simple. There's little associated morbidity if it's done by the right surgeon, and also these patients have a short recovery time. The initial success rate is said to be 50 to 80%, which is quite high, but there is a high incidence of late failures, and that's because of regeneration of nerve fibers, and this can occur months to years down the line. You essentially, if you section both chorda tympani, as we know, this will cause loss of taste of the anterior 2/3 of the tongue, which should only be done unilaterally, and it's contraindicated in anyone with a unilateral sensory neural hearing loss. So salivary duct ligation. So of the 4 duct ligation technique has been described as simple and minimally invasive, and in this technique you ligate both parotid and submandibular ducts. The top image shows identification and then ligation of the submandibular duct, and the bottom image shows identification and ligation of the parotid duct. The advantages of this procedure is that there's a lack of any external scar, and you avoid any potential nerve injury. The success rates it's a wide range, but it varies between 30 to 100%, and it's variable because of many factors. The recurrence rates are reported to range from about 0 to 70%, and the timing of recurrence is at about 3 to 9 months. And this is important because you should follow your patient up within that period. They may have a lower success rate compared to other surgical approaches, but the data on this is quite limited. Moving on to submandibular duct transposition. So this is also quite a historic procedure, but still very much in use today. It was first described in the 1960s. And the technique is that you perform a bilateral transposition or relocation of the submandibular ducts from their normal position to the inferior pole of the palatine tonsil. So this image shows before or the normal appearance, and after the operation, how it looks. So the submandibular glands are the obvious target because they produce 70% of the salivary output at rest. And in terms of the outcomes following this procedure, so you get a significant reduction in the severity of drooling, a decrease in the amount of daily care required, and reduced economic consequences, as well as increased social contact. And that's from a study published in 2007. In terms of complications, there are few, but none of them are major. So there's some floor of mouth swelling, which is found to settle within a few days. but that might prolong this patient's hospital stay. There's been reports of arenular formation, sialoadenitis, sialolithiasis, as well as aspiration, and that's because you're now you're relocating the duct more posteriorly. It's there, and that's why it's contraindicated in posterior drooling. There was a 15-year case follow-up by a researcher who's done quite a bit of work on this topic, and he found that over 90% of patients parents reported benefit, and 50% reported complete cessation of drooling, which is quite a good success rate. And then moving on to submandibular gland excision. So this is a technique that's suitable for the management of both anterior and posterior drooling. Traditionally, it was done by the transcervical approach, which I've put an image of on the top. The obvious kind of risk of that is injury to the marginal mandibular and other nerves running in that area. Therefore, some surgeons attempted or have been performing the trans-oral route, because this avoids a cervical scar as well as injury to the marginal mandibular nerve. The overall success rate of this procedure is said to be 63%, and there have been significantly improved subjective outcomes. Okay, so should we consider a combination of procedures, or these procedures only meant to be done in isolation? So there was a study done by O'Dwyer, which is a surgeon who's done quite a bit of work on this, as I mentioned earlier, and he did a prospective comparison of submandibular relocation versus relocation plus excision of the sublingual glands. And the conclusion from this was that both procedures were effective. And there's no question about how effective they were in controlling the drooling. There wasn't any statistical significance in the patient's drooling scores and parental satisfaction after the surgery. And the addition of, what they did mention though, is that addition of a sublingual gland excision does increase the operative time as well as the length of hospital stay, but it also increases the patient's morbidity. And the specific things they mentioned was post-operative bleeding, post-operative pain, as well as a longer time to commencing oral feeds. Okay, so this I included just because I thought it was quite a nice summary of the approach and what you can do if you're concerned about this child and you want to start them on an algorithm-based management. And this is what they use in the department at one of the teaching hospitals in the UK. I won't go through it all again because it's what I've already mentioned, and some of the things that they mention aren't necessarily available in our setting, but I didn't think it was quite a nice summary. So that brings me to my conclusion. So the assessment and management of these children is best coordinated by a multidisciplinary team. According to the global guidelines, the most well-known being the NICE guidelines, there's multiple possible treatment strategies, but the options are, as I mentioned, somewhat limited across our city, in our setting as well as across Africa. And so we should bear this in mind when reading the guidelines. There are a variety of medical and surgical treatments, and this suggests and implies that there is no gold standard treatment. Therapy-based and conservative options should be considered first, and if these resources exist in your setting. The published evidence for many of these treatments is very sparse. And the most important thing is that your aim should always be to improve the quality of life for each individual child you see, and you should offer them the best treatment that you think is fit for their particular concerns and problem. Okay, thank you very much for your time. That brings me to the end. These are my references. I've got Dr. Katundu next to me, who's our pediatric fellow, and he can provide also some insights and maybe just add on now. Thanks, Dennis.
Thanks very much, Leila. This is as we've been chatting, this will be it's one of the nice presentation first, and the second thing is one of the very important topic to recall as far as what has been invented and been applied over time for these kind of children whose concern is not only functional but also cosmetics in that essence. So we have seen a lot of these children, and we've done a number of them. And now the question is which technique we have been doing. But most of the time, from our setup, we've done both the Botox injections, and we have done the combination of duct relocation and some lingual gland excision. And we have seen quite a good satisfaction and outcome. So I think this goes in line with our next few months Congress for reciting some of the forgotten techniques and approaches toward management of different basic ENT conditions. So I think it's very important that we should recite some other time again in different occasions. And if we can get a chance, probably later you can present this in the Congress and present a few of our cases that we have done. Thank you very much.
Thanks, Dennis. If there's any questions from any of the other participants, we're happy to, or comments, we're happy to discuss.
Will ask Martin to comment on that facts.
On the call. Yeah. Thank you, Leila and Dennis, for that fantastic presentation.
Sorry, Shavina, can I ask a question?
Sure, yes. Hi, Charles.
Dennis, hi.
Hi,
I wanted to find out, is there any role for a tonsillectomy when you're doing these drooling procedures? For example, when you're going to do a submandibular duct diversion, would you do a tonsillectomy in the same setting? Is there any benefit in doing a tonsillectomy or not really?
So really, there is no any defined role for doing tonsillectomy in the same setting because of the whole pathology involved in this kind of children. And now the question comes, when you are doing a combination, how long do you take? Because we have really showed you have to bring the duct close to the tonsil, but there are quite a negotiation on that, and you can bring it to the second molar, which is still applicable. So to confirm with you, the studies and the practice have shown there is no really benefit of doing tonsillectomy, as understanding other morbidities associated with tonsillectomies.
Okay, thank you.
Are there any more questions or comments from the panel?
Maybe the only thing I could add to that, Charles, is that what I did read in one of the studies was, if the child has big tonsils and you're doing a transposition or diversion of the duct, if the tonsils kind of get in the way, and you've got enough duct length and you've decided you're gonna transpose to the inferior pole of the tonsil, you can do a tonsillectomy to create space, I guess, so that your duct is sitting kind of in a kind of open space and not then occluded by a big tonsil. But as Dennis said, you do have the option of transposing to this second molar, so it's not I don't think it's a necessity, and it probably adds just more morbidity, child at risk of bleeding and all of that, so it's not a must.
Yeah, thanks, because I think I also came across something about staging it and doing a tonsillectomy first in a child with big tonsils, and then proceeding with the duct diversion if the drooling is persistent. But yeah, I think it was quite a while ago. I'm not sure, I wasn't sure if there was any kind of evidence with that. We actually had a child with trisomy 5 that we actually debated, whether we should do, is got quite significant drooling, and we're debating whether we should also do a tonsillectomy. It's got borderline grade 2 or 3 tonsils. So we're quite debating whether we should start with the tonsillectomy first and then do duct diversion later. But of course, there comes to play the issue of theater time and affordability, because the private patient as well, and they will be charged double in terms of theater time if we stage the procedure. So I think in that setting probably we may then end up taking the tonsils at the same time. But yeah, thanks for the response.
Yes.
So, Leila, you can correct me if I'm wrong, but my understanding of the role of specifically adenoidectomy and to an extent tonsillectomy and anterior silarrhea is more, it's one of the factors like the oral hygiene we want to address because it can mimic or exacerbate silarrhea. So if they're chronically mouth breathing because they're obstructed by their adenoids, that will exacerbate or mimic silarrhea, as opposed to it being something you do in conjunction with ductal rerouting. If that makes sense.
Yes, yes, exactly. I think you've summed it up well. That's exactly why you would do it. I read exactly the same thing. I don't know if Dennis has anything to add.
No.
Yeah, no, that's exactly it. Yeah.
Yeah, thanks, Data. Thanks, Matt.
Are there any more questions or comments? Well, thank you, Leila, and thank you, Dennis, for that presentation. If there's no more questions or comments, we'll end the meeting. We'll see you next week. Have a good weekend.
Thanks everyone for joining. See you. Bye.